And it looks like some transcription has started. Let me stop that. There we go. Okay. All right. So, first of all, I'd just like to welcome everyone to the talk this evening. Thank you all for attending. We will make it a nice slick talk as we always do. We have a few speakers here today, and we just first of all like to just thank them for taking the time to come talk to us in this lovely Wednesday evening. Our first speaker, before I get into the pain talk presentation, will be Kira from Lantham. I've met Kira very recently at one of the Lincolnshire Practice Manager talks, and she's very interested in talking to us about Lantham and getting onto the staff bank to help GPs provide support for practices in Lincolnshire, but also just to tell us about the wonderful work Lantham is doing in Lincolnshire. Once we're done with that, we'll get on to introducing our main speakers for the evening. Okay, so Kira, when you're ready, please crack on. Thank you.
Lovely. Thank you very much. And thank you for inviting me to speak and for having me at the beginning of this talk. I won't take too long to go through the presentation, but I just wanted to jump on to give you a little bit more information about Lantham and what Lantham's doing within Lincolnshire. Hopefully some of you have heard about us already. So Lantham is a connected scheduling platform. So we use technology to simplify healthcare staffing. So our main aim is to unite all clinicians with primary care organisations, and we try and make that as simple as possible for practices and also for yourselves. So we want to make sure it's easy for you to find work and connect you with all of the practices within your area. So there's lots of benefits of using Lantham. So the main platform as a whole makes locuming within the area really simple. So clinical governance, all of your clinical governance can be managed in that one place on the bespoke app. So it means that if you are going to work a shift in a practice, they can see all of your clinical governance there, and you don't need to be sending anything back and forth with them. All of the paperwork is automated, so it means that timesheets are generated directly after you work a shift. Timesheets then are processed into invoices, and that is all done on the Lantham platform. And it's the same with pension forms. So all of your shifts that worked will generate pension form A's, and that will be condensed into a pension form B pack at the end of the month for you. We have a fantastic customer support team that are always there to provide support. And of course, the platform is completely free to use. So you've access to using the platform on a desktop, and then we also have a bespoke app which is free to use. So it makes it a little bit different from the traditional locum agencies where you essentially have Lantham in your pocket. It really does save you time using the app. You can filter your availability to make it nice and easy for you. Find work nice and easily, negotiate your shift rates, and manage your schedule all in that one place. So specific to Lincolnshire ICS, because Lincolnshire have partnered with Lantham to help with the staffing, with filling shifts, they have agreed different incentives that we can provide to yourselves and to Lincolnshire practices. So one of the biggest ones and one of our most popular ones is the free rocket pay. So normally there is a fee for that, but for anyone working shifts within the Lincolnshire ICS, that's completely free at the moment. So it means that if you decided to work a shift tomorrow on Thursday, you would get paid on Friday for that before the weekend. So you'll get paid the next working day for any shifts within Lincolnshire ICS. Another incentive that we've just launched for Lincolnshire is refer a friend. So if you do already happen to have signed up with Lantham, you can refer a friend and both of you will get £50 once you are both approved on the platform. And again, with DBS, Lantham offers a free DBS check to any GP who signs up and works through the platform. So it saves you time, saves you hassle, and that's free service as well. So just a couple of things that have come back to us in feedback from clinicians that are using Lantham. So lots of feedback that it's saving time, it gives you control, it really empowers you to manage your schedule. And there's always support on hand to either help you sign up, to help you get approved, or to help you find shifts within your region. So to get started with Lantern, it's a nice and simple process. So firstly, you need to sign up. I will be sharing, I think like I may already have shared with you, the link to sign up specifically for the Lincolnshire ICS Bank. Please don't sign up through the main Lantern website, because it will not add you straight to the Lincolnshire Bank. So use the Lincolnshire page to sign up and it will add you into the bank. Once you have your profile set up, you can upload your core documents. So there's 3 documents that we have to have for you to be approved to work on the platform, and they are your DBS, your CV, and your passport. So if they're uploaded, they can be checked within 24 hours, and then you are ready to work. Again, you can upload other training as well if you would like to keep all of your clinical governance documents on the platform. Once you are approved, you can find work straight away. So you can go to the find work page and start finding shifts that fit with your schedule. And then you can also look for the free Rocket Pay shifts, so meaning that you can get paid the next day. And that's at no extra cost to yourself or to the practices either. So that's a quick whistle-stop tour of Lantern and what we're doing within the ICS. I will send over some additional links that you can use. But of course, if you do want to be put in touch with me, please do ask for my email, and I am happy to support anybody in getting set up. So I am the activation manager for Lincolnshire. So if any support is needed, you are more than welcome to get in touch. And a big thank you again for having me on the talk today.
Thank you, Kira. Thank you for joining us. And please do share the details with me later, and I'll forward it on to the team. All right?
I will.
Excellent.
Indeed.
Thank you. Cheers. So I'll just let Graham put his presentation back up when he's ready, and I'll just be introducing Graham. And if it's okay for Graham to introduce Alistair. First of all, I just want to thank you both for attending and for helping talk to us about the pain management service in Lincolnshire, and as well as an update on pain management generally. We have 2 speakers today. Thank you, Graham, for organising the talk and for bringing in your colleague, Alistair. So we have Alistair James, an advanced physiotherapist and non-medical prescriber, who is going to update us on the Lincolnshire Chronic Pain Management Service, as well as the update on NICE guidelines relevant to chronic pain. So very relevant stuff. And then we're going to go next to Graham, who we all probably know very well, because he wears many hats. And based on our relationship from a different setting, I got to find out he's really into chronic pain, and said, oh, we really love this. We would love to learn about chronic pain. Such an important thing. It's a difficult field to manage, and it's lovely that he has organized this talk for us. So thank you so much for that. Now, just a little bit about Graham, because for those who don't know Graham, the way I got to know him was through being an appraiser. So he's an appraiser. He was my appraiser, and he's been an appraiser for quite a few of us already. But also he wears a more significant hat in the sense of in the chronic pain team, and which I believe it's one of his main passions, in that he's gone further. He's completed his MSc in pain management at the University of Cardiff. He even tutors on the course now. I know he's passionate about it because he's mentioned it. He also has an interest in hypnosis, and he's a member of the British Society of Clinical and Academic Hypnosis. So worth also speaking a bit more about that when you get a chance, Graham, because I think that's quite exciting. And he's been working, as you know, on the chronic pain team in Lincolnshire for a couple of years now. And as you also know, he's a GP by background. So Graham, without further ado, please take it on. Thank you.
Thank you, Lucky. Yes. Thank you very much for organising the talk tonight, and thank you for having us to, as you say, talk about our passion, which is pain. So I hope everyone is well and everyone's having a good day. So about 3.5 years ago, the pain management services in Lincolnshire changed from a primarily hospital-based service to a community-based service. And that allowed people from a wide background, including myself, to specialise in pain management. And that's a trend that we're seeing happen across the country and beyond. So I'm very thankful as well to have Ali here with me tonight, who's one of the team leads within the service. So I'll just let Ali come on and introduce himself.
Yeah, hi, my name's Ali. I've just noticed that someone's gave me a ridiculously long job title there on the first page.
That was me.
Was that you? Yeah, my role certainly developed over the last 3 years in the paint service. Currently, I lead a team of advanced practitioners, and the bulk of my work these days is around non-medical prescribing in pain and around direct listings, so injection assessments as well for spinal injections. So when I got the brief for this talk to give a bit of an update on the service, I reflected really on how busy the service is and how much it's changing. And so I decided to narrow it down a little bit, although happy to answer any general questions after I've done the brief update, and just chose 2 topics. So the first one is talk a bit about our pain management programs, because I think it's something as a service we're really proud of, and it's a really good opportunity to be able to spread the word a little bit. I think we're really lucky as a service to be able to offer a program like this. You know, when you consider the national average for someone with persistent pain in terms of specialist input is 3 to 5 hours a year, which is, you know, really, really low. Where our pain management program, people get to attend for each session's 3 hours, and it's an 8-week program with then a 3-month follow-up as well.
Can I just stop you 2 seconds, Ali? You
Sure.
you're just jumping the gun slightly, so you're very keen, but we'll just that was just to say who you are, and then we'll just do a brief outline of what we're going to do, and then you can go for it.
Okay.
So have you finished saying who you are?
Yeah.
Okay, so just a few, so that's the introduction. As Lecky said, I'm Graham Dunthorne. I've been a GP since 2014, and I've worked in pain management since 2019, and that's my primary role since about 2020. Did the Masters in Pain Management alongside that, and as Lecky said, I'm a GP praiser, and I'm a GP lecturer with Nottingham Uni based at Lincoln too. So a few disclaimers before we just rush into it. So pain is a subjective entity, as we're going to hear about, and the talk involves our own perspectives and our own reflections, particularly mine at times, and so they're not necessarily the perspectives of the ICB or Connect Health, which have their logos on this presentation. So they're based on our personal experiences and exploration. We are going to be talking about communication and consultation, pain consultations, and I always think there's a bit of a risk when you start talking about this stuff that it sort of comes across a little bit arrogantly. So just want to be clear that we're not suggesting that we're any good at any of this stuff. It's really just a reflection between peers. There's some artwork throughout this presentation, which is being recorded now. This artwork has just come from Google, really, and it's referenced. And yeah, we're just using it to enhance the presentation, and we're not receiving any sort of financial reward for that. Timings wise, we're just going to do our best, to be honest, so just bear with us on that, but we can go up to 9 o'clock for questions if necessary. Okay, so Ali's going to do this update on the chronic pain management service, take a few questions there. If you can put questions in the chat as you go along, and then we'll just kind of break for them at convenient periods. I'm then going to talk about negotiating chronic pain consultation in primary care, which will be a reflective review. And I think we'll have a quick break there for sort of 5 minutes of comfort. And then we're going to talk about medication a bit at that point. Okay, you're up, Ali. I shall go away now.
I only got it wrong in the first 5 minutes, but we'll gloss over that, it's fine. So I was just saying that we're really lucky, I feel, to be able to deliver a face-to-face pain management program, and the volume that we can deliver as well. So just get to the slide. So like I said, it's 3-hour program thereabouts for 8 weeks, once a week, plus a 3-month follow-up session as well. The core of it is that it's psychology-informed pain rehabilitation. So essentially, to summarize that in a couple of sentences, it's about establishing some values-based goals and then supporting patients to move towards that in the presence of pain. We run these programs across numerous locations in Lincolnshire. We try and base that on patient needs. So where we get a list built up in an area we don't currently have one, we try and provide one in that area. Core areas at the moment really are Spalding in the south, Lincoln centrally, and then Mablethorpe more on the coast. There's three outcome measures that we use to measure the success of the program really. PSEC is the main one, which is a measure of pain self-efficacy. And then we also measure depression and anxiety with PHQ-9 and GAD-7. It's worth saying that the program doesn't specifically target mood, but we do see changes in mood when we're delivering pain rehabilitation. So it's a useful thing to measure anyway. So the data that we've got today was across 8 different programs, so 46 patient totals from 8 programs across.
Sorry to jump in there, Alistair. Sorry, is the slide moving? Is it just on my end that is stable? Yeah, perfect. It's moving now for me. Thank you. Lovely. So we're now on the pain management program outcome slides, and I think now you've just gone on to. Yeah, this is where we are. Perfect. Please carry on.
Give me a hand up, Ali, when you want me to move your slides along, and I'll do that.
I'm on slide 5. It was moving for me. I assumed it was moving for everyone else.
You may want to take control there, Alistair. There's a little button that says take control on the top. If you want to click on that, I think it'll give you control of the slides.
Yeah.
You want to see if you can test that out? There we go. That's it. It's moving now. Perfect.
So can everyone see slide 5 now? Is that?
Yes, pain management program outcomes.
Yeah, perfect.
Yeah, excellent. Thank you.
So at just a brief overview of the outcomes really, it is 37 of the 46 patients at the start were above the threshold for anxiety, and 22 were above the threshold for depression. So at the end of the program, so at the end of the 8 weeks, the GAD-7 dropped from 37 to 25, so 29% of the patients dropped below the threshold for anxiety, and then 42% of that was maintained at follow-up. The interesting thing as well was there was a further 25% drop below the threshold at the follow-up as well. So not only was a good maintenance, there was further improvement as well. We saw similar in the PHQ-9, that the number dropped from 22 to 18 at the end of the program, so 22% drop, 60% was maintained at follow-up, and a further 40% drop below the threshold at follow-up as well at 3 months. So for a program that's not specifically targeting mood, it was a significant change. The PSEC was where we saw the main change really, which is what we're really proud of. You know, we noticed an average change of 12.7 after the group and a further 3.3 at follow-up, which is an enormous change for PSEC. And when you compare it to PMPs in the research literature, the group we're delivering in Lincolnshire, on the face of it with this data, outperforms even the most effective that's reported in the literature at the moment. And then this is just a little bit on how we've changed the introduction to the pain management programs, which I felt was important for the community to know about. So the history of PRISM, which was our introduction session, was started quite dynamically at the beginning of the pandemic, where overnight, all of a sudden, we were told we couldn't deliver face-to-face. So we came up with this introduction program that we could deliver virtually. And we've developed that recently into more of an introduction session for pain management programs. So what's really good about it is when we have patients that are not sure about committing to engage for that volume of time, which is often difficult for patients, they can come to this introduction session, and it just tells them a bit about the pain management program, what we're going to be delivering and what we're expecting from them in terms of active engagement as well. And then patients can opt straight into the program from that. It is delivered virtually, the pain introduction session, but for patients that can't access that for whatever reason, it's not compulsory. Patients still can access the face-to-face program. And then I've just got a little slide with patient feedback, because that's always the most meaningful feedback, I think. And this is often really useful for patients, because often the biggest barrier to attending these groups is patients feeling like it might not be useful, or for just a nervousness of engaging in a group. So often just showing patients some of these comments from previous patients is really powerful. So I just wanted to share that as well. Did we have any questions about the pain management program just before I move on to the opioid pilot?
Yes, if you don't mind, just a quick question about the volume of patients in the group. How many on an average would you say in each group? And do you sometimes decide that based on an individual's experience, they would rather work on a one-on-one basis, or does the service have the capability to do that?
Yeah, so absolutely. We deliver one-to-one work with patients, whether that's face-to-face or on the telephone or via video at patient's preference. And this is just part of the pathway. In terms of group numbers, the maximum is usually 12. Sometimes it's a little bit lower just because of location and room sizes and things like that. But we try to keep it to 12, and there's usually 2 clinicians that deliver that. So there's usually one of our clinical psychologists, and then a physio or a nurse. And then we usually have a prescriber drop in for one of the sessions as well to do a bit of a talk around pain medication.
Excellent. Thank you for that. Just a couple more questions from colleagues. One of the questions one of my colleagues is asking very quickly is that what they were saying actually is that they perform chronic pain reviews in their surgery. They lead on that to try to reduce the opioid use and dependence. And they're just wondering if they get to a point where they struggle with a particular patient, is there an A&G service, an advice and guidance service, or someone they can pick up the phone to talk to about the patient fairly quickly? What sort of options are available to support practitioners rather than having to refer patients formally to your service?
Yeah, so we do have an established advice and guidance service. So it comes through at the moment through System 1 to a dedicated task group for those inquiries. We tend to be able to respond relatively quickly, usually within a couple of days, and we often arrange a call from that if it's needed. So yeah, that's absolutely available.
That's very good. Actually, I've never used it, so that is news to me as well. I know there's advice and guidance for almost every specialty, but that's excellent. You said system one, but would that also be open to EMIS as well for EMIS practices, or it's just a message from a secretary to yourselves?
Yeah, so the way it works is if it's an EMIS practice, it comes through to our patient contact centre, and they convert it to a task for us so the clinicians can see it. So there's just a bit of a middle admin step with EMIS.
Sure. The final question from the other colleague is about fibromyalgia. They're asking, do you see fibromyalgia patients in your service?
Yeah, absolutely. So fibromyalgia falls under that umbrella of primary persistent pain now.
Yes.
Yeah,
yes. I was going to say that we invited a rheumatologist a few months ago, and she was very adamant sent to the pain team. So, but it's good you've reinforced that. Thank you very much. All right, let's crack on. Thank you very much. You can crack on.
To go to the next slide. The second thing I wanted to talk about is quite topical, our opioid reduction pilot. So both Graham and myself have been core members of clinical reference group for opioids in Lincolnshire, and as part of Connects Health's contribution to that bigger piece of work is we've agreed to pilot a separate pathway for opioid reduction. So it's set to launch in January, hopefully. And initially, we're just accepting 20 patients from the Boston PCN. And the criteria really is that these patients have been identified as taking more than 120 milligrams morphine equivalent a day, which we know British Pain Society flags as increased risk and no increased evidence of increased efficacy above that dose. So it felt like a reasonable threshold for the pilot. The way it's going to work is that patients are sent out a letter from the PCN inviting them to opt into the programme with a bit of information on why they're being invited and the background around the risk of opioids. And then the patient will be consented by the GP practice, either by a GP or a community pharmacist. And then the patients will come through to us, and we will provide a 60-minute holistic assessment that does have a focus around medication, but it is a wider assessment with the aim of agreeing an opioid reduction program at the end of that. Patients will get access to our full offering as well if there's a need for that and they want to engage with that, they can move to our normal pathway. But then the difference with this pilot really compared to our normal medication reviews is then that opioid plan will be handed back to primary care, and our colleagues, community pharmacists, will deliver that reduction plan and monitor it. And we will provide support as needed if there's any problems along the way. So I think it's a really exciting project, really, to be able to work in a more integrated way and support each other. And so I think that's quite exciting. I think I've covered that slide already, getting ahead of myself. So was there any questions first about the opioid reduction pilot and around the pain service generally as well?
No, we're good. Thank you. Very well explained.
Just that one question there, how often do you interact with patients on the opioid reduction pilot? So the patient will have that initial assessment, and then it will be at our discretion whether the patient would always have an opt-in follow-up open to them, but it would be our discretion whether we make a formal follow-up appointment or whether we basically give advice to the GP. Ultimately, there's so many patients in Lincolnshire on high-dose opioids that we need to work more closely with the community and support the community to make those changes if the project is going to be scalable. When and where is the next pilot? So Boston PCN is the first pilot, and then we are probably going to try to develop ones practice-specific pilots down the East Coast initially, because that's where the major hotspots for opioids are in Lincolnshire. And that's got a lot to do with the social and structural demographics down the East Coast. Opioid prescribing tends to follow social deprivation. So that's where we kind of go first, but we're also trying to develop some wide educational pieces to support GPs working elsewhere in the county. And going back to that question in the chat about people who are obviously managing these things really well by themselves in their own practices.
That actually leads to a question, because when I saw the pilot statement and I saw 20 patients, I just thought, obviously it's a small number and you need to just prove the concept first. So I wasn't actually looking at it as a means of sending my patients to you. However, I actually have a question that's come up from that. Is there something you can give us to go away with, in the sense of, would you recommend that we should audit our patient populations to see if we can summarize how many patients are over 120 milligrams, for example, per day of opiates, and then potentially collect this group of people and forward them onto yourselves? Or first of all, maybe rather than doing that, maybe you may have a step-by-step guidance on how to help these individuals come down below the 120 milligram dose, which I believe your pilot is hopefully going to help establish some certain learning pathway. But you obviously have things you already can recommend to us to do and to use. So it might be useful for us to use that to disseminate that information to the rest of the group while waiting for your pilot to kick in.
Yeah, it's a really good questions. So I'll just try and go through those briefly. Number one, obviously, the opioids are not the absolute focus of tonight's talk, but we are through the CRG trying to develop an opioid talk, so we'll certainly be able to come back and give that one. There are new guidelines on tapering opioids going to PACEF this week, so they should be available soon, and they will be reviewed in 12 months as well. There is a new prescribing charter for Lincolnshire under development. And finally, yes, if you find complex patients above 120 milligrams a day, then by all means, refer them to the pain service. If you feel that you can begin to taper them, have that discussion with the patient using the tapering guidelines once they're available, then absolutely, by all means, have a go. If you're unsure, I'm always happy to receive an email, an advice and guidance, something like that. My own feeling on this is that you generally can't, if you talk about oral morphine, you generally can't go wrong reducing by 5 milligrams of the total daily dose. So if you think of a patient on 100 milligrams a day of morphine, for me, a lot of it is about giving that patient the confidence that when you make small reductions, that they will be okay. And they won't experience significant increases in pain or significant withdrawal. So just reducing their total daily dose by 5 milligrams for a couple of weeks and having a quick chat and saying to them, how do you feel? And when they say, I've not really noticed the difference, you say, should we do another 5? And, you might have 2 or 3 patient contacts at that point, but once they're off and running, you'll find that many patients will happily just self-manage that reduction and just come back to you if they need to. So I hope that's very brief, but I hope that's
very useful, very useful. Thank you so much.
Fantastic. I just wondered, Ali, whether you wanted to just kind of say in sort of 60 seconds, you talked about ACT-based pain management programs. Did you want to just summarize what ACT is? Can you do that in 60 seconds?
Oh, wow. Yeah, that's a toughie, isn't it? Yeah, so acceptance and commitment therapy. So I guess to summarize in a couple of sentences, it is moving away from a pain control agenda. So moving away from the seeking of diagnosis or a resolution for pain, and moving towards the idea that if this pain is going to be there for the foreseeable future and we may not be able to influence the intensity even, how do we support this person to be able to engage with life and the things that are really important to them alongside the pain. So there's lots of different pain management strategies covered on the course, but just to list a few, I guess it covers things like a modern understanding of pain science. It covers practical strategies like pacing and activity management, how to manage tricky thoughts and feelings that often come with pain and get in the way of things, which tends to be an acceptance and commitment approach laced with some compassion focused therapy as well, some input around how to sleep well, around the safety of movement and exercise despite pain. So it really is a broad program.
Thank you. Yeah, and so acceptance commitment therapy is a third wave therapy. So behavioural therapies being first wave therapies, and then CBT being second wave therapies, and then the third wave therapies were more about acceptance. They started to be developed in the 90s when some people started to decide that trying to restructure people's cognitions in CBT, trying to dispute their thoughts and restructure them, wasn't particularly helpful in lots of patients. And so the third wave therapies were developed more around the idea of accepting thoughts. And that for that reason, it lends itself quite well to pain, where many people have had pain for 10, 20, 30 years without any noticeable change in their pain levels. Fantastic. Thank you, Ali. Were you providing resources pre or post pilot? Yes, so the Boston PCN are getting some teaching at some point to support the pilot, and that we are hoping will become a scalable thing, but it is all ultimately around resources. Could I get control? Well, yeah, take control. That's what I do, isn't it? Okay, so I'm going to talk about negotiating a chronic pain consultation in primary care. And the reason I decided to talk about this was because when speaking with other GPs about chronic pain, the most common question that seems to come up is, what can we actually realistically do in 10 to 15-minute consultations? So that's something I've reflected on a lot, and I've decided it's definitely not an easy answer, but I'm going to do my best to give you my own reflections on that. So a little bit of historical context to all of this. So this is John Bonica. So he was a Sicilian-American anaesthetist, and his passion for pain, as I understand it, started when he was treating World War II veterans. And he realized quite early on that pain was so complex and so multifaceted that many of the issues that his patients had were beyond his scope as an anaesthetist. So he started to draw in his sort of team members, his colleagues, and he established the first ever interdisciplinary pain service in Seattle. I think that was in the 1960s, and then sort of over the next decade, that became a bit of a trend, and more clinics sprung up throughout America and beyond. That trend then got replaced, and primarily it got replaced by the opioid crisis, but there was also a rise in other sort of pain interventions. And as we all know, there were economic and pharmaceutical and political drivers for all of this. But eventually good sort of reason, good science catches up a bit. And, really in summary now, we understand that whilst opioids and other pain medication really may be effective for short-term pain, for acute pain, and for cancer pain as well, the vast majority of people who take long-term opioids for chronic non-cancer pain will not experience significant benefits in pain levels, in functionality, or in quality of life. Just move my slides now. So times are changing again, and we're gradually going back towards the multidisciplinary model. And that is once again widespread now. Approaches are developing and changing all the time. There are many different pain thinkers out there now, different models, different approaches. And I put the story of Copernicus up here, which I've seen compared to pain management. So the sun rises in the east and it sets in the west, and it's always risen in the east and set in the west, and it will always do that. And Copernicus, of course, is famed for, through his observations, realizing that actually, whereas people previously believed that the Earth was at the center of the solar system and the sun orbiting the Earth, Copernicus realized that this was not the case, and actually the sun was at the center of the solar system with the Earth orbiting the sun. But of course, beyond those kind of groundbreaking revelations, the sun would still rise in the east and set in the west, and on the surface nothing had changed. So in pain management, you know, our patients still look the same. We still see patients with the same pain and the same lives, but our approaches to pain behind that are really changing, and that is going to revolutionize and is revolutionizing the way we do things. So to try and go into this a little bit, I am going to talk about what pain is. I'm going to have a go at talking about what we might be able to do in a 10 to 15-minute consultation. And then we're going to take a little moment for sort of break and questions, and then we're going to do a little bit around medication beyond that. Okay, so what is pain? A challenging question. And just to set the tone, between love and pain, most of life will be covered. So just leave that with you. So to really think about what pain is, I'm going to think about first what pain is not. So pain is not objective reality. Pain is not predominantly biomedical, and pain is not easily measurable. So we're going to go into those things a little bit. So we're going to do a little exercise now with this apple to just consider this idea of objective reality. So just have a little look at the apple first. And then this is something I would suggest doing with cameras off. So if people just want to turn their cameras off to allow them to just relax a little bit more. I seem to have a bit dry, so I'm just drinking and drinking. Okay. So if anyone has a particular aversity to apples, or if anyone has any particular difficult memories associated with apples, then I would suggest not doing this exercise. But otherwise, when you're ready, just close your eyes. Close your eyes. And just taking a moment to relax now. And you can just let each out breath you take relax you a bit more. Relax you more deeply. Just allowing the sound of my voice to guide you deeper. And just allowing the words that I speak to help you to relax too. And when you are ready, just let your mind take you back to a time when you were eating an apple. Don't need to think about this. Just let your mind land somewhere. Might be the last time you ate an apple. It might be another time. Really doesn't matter. Now you may already be taking a bite out of that apple. And if you're not, just take a bite now. When you bite into the apple, just hear that sound that it makes. And taste those tastes. Could be sweet, maybe bitter, maybe something completely different. And just notice the smell as well. Just take a moment to enjoy your relaxation and let those senses build inside. Okay, and then when we're ready, we'll say 1, 2, 3, and back to the presentation with full alertness and everyone's cameras. Okay, so the apple is an object, and the apple has features of objective reality. So the apple has dimensions, the apple has a volume, the apple has a mass. But the apple also has elements of subjective reality. So the apple has a colour, the apple has a sound as you bit into the apple, it has a taste, it has a smell. And all of those things are elements of subjective reality. And that means that they require a human to be there to experience that reality. These features have no objective reality. They do not exist without the person there experiencing them and witnessing them. And pain is like this. So pain has no objective reality. It only exists because you have a human being there experiencing that pain. So this means that pain is not predominantly biomedical. It has individual context, it has environmental context, and it has humanitarian context, but it's not predominantly biomedical. So with this picture, I'm not trying to suggest that diabetes is all biomedical, and obviously it has an illness lived experience as well. But clearly there are biomedical features. There is an HbA1c to measure. We prescribe drugs according to that. We monitor the HbA1c and we adjust treatment. And pain is really not like that at all. For the vast majority of people, apart from maybe a few people with ongoing rheumatoid arthritis or something, and where we can monitor inflammatory markers, there is really nothing biomedical about pain. So pain is not easily measurable. It is subjective, it is always perceptual. But it's important we remember that pain is always important and pain is always real. So this little quote from Rita Sharon: the only instrument that can register the presence or intensity of pain is the human witness. Okay, so what chronic pain is then? So chronic pain is an embodied, persistent prediction of harm. So embodied refers to that same thing, that this is subjective reality. There is always a person. Pain is a conscious experience which is generated within the brain. But we are not simply a bit of consciousness swimming around. There is always a person, there is always a body. People live, people interact through their body. So pain is embodied. Persistent refers to this idea of 3 months, which I'm sure everybody knows. And 3 months refers to this idea of normal tissue healing time. So beyond 3 months, we can consider in the vast majority of cases that the tissues will have healed. And this means that It's beyond the time of normal nociception. So when you step on a pin, we all know that you get nociceptive danger signals that are transmitted to the brain where they're interpreted and people have a pain experience. And this experience protects you. So it protects that area of the body. But we also know that if you've still got pain in your toe 6 months down the line, then you still don't have a tissue injury. And you probably do not have ongoing nociception either. So persistent refers to 3 months beyond normal tissue healing time, beyond normal nociception. So prediction, an embodied persistent prediction of harm. So this refers to the fact that the brain is primarily a predictive machine. It works in a top-down way rather than a bottom-up. So this refers to the fact that the brain is constantly monitoring its internal and its external states. And whereas in the past we've considered the brain to be a sort of computer that's constantly analysing sensory information and interpreting it, we now understand that what the brain is actually doing is that it's constantly predicting what's likely to happen next in its internal and external states. And it's comparing what it thinks will happen with the sensory information that then comes in. And it only acts to change if there is a significant disparity in those things, what we call a prediction error, at which point it will change its prediction of what it thinks is happening. And this is really important because what we can then understand is that the brain doesn't necessarily always get this right. So this is the checkerboard illusion that you commonly see in chronic pain consultations. So the brain has a perception of what it's seeing here. And when we look at the squares A and B, I'm sure that everyone noticed that their colour appears quite different. But when we change the information by putting the rods on, we see that the perception of what we're seeing is completely different. And that A and B are in fact the same colour. And this just shows that with these subjective experiences like vision, hearing and pain, the brain does not always get it right. It's making its best guess of what it thinks is happening. So in the case of chronic pain, when you've stepped on a pin 6 months and you still have pain in your toe, the brain perceives that protection is still required for that area of the body. But in the case of persistent chronic pain, the brain is misinterpreting the situation because we know that protection is no longer required. And in fact, what's happening is that gradually the patient is losing functionality and losing quality of life. So it's become maladapted. The brain is misinterpreting the sensory information. So harm is obviously just harm, but it's just important to remember that it's actual or apparent harm. So there doesn't have to be actual harm going on. And sometimes it's better referred to as danger signals in terms of nociception, and that pain is ultimately trying to protect us. So we have a bit of a job to explain some of these things to our patients. And I've just popped those up because they're two really common things on YouTube, Tame the Beast and Understanding Pain in Less Than 5 Minutes, that people can watch. And, you know, many people find those things very helpful. Personally, I just like to try and work with what the patient tells me, with their story. But there are a few things that I think can run through the consultation when we're trying to explain pain. So it's useful for patients to know that we have a pain system, and that if this involves your brain and your body, or your mind and your body. And it's useful to see this as from a non-dualistic perspective, which basically means that that the mind and the body are highly integrated, and we don't consider them to be completely separate entities. It's quite useful for people to understand that in persistent or chronic pain, the problem tends to be with the circuitry, with the wires, with the communication between the body and the brain, and not with the tissues themselves. It can be useful for patients to understand that the part of their body is not sending pain signals, it's sending danger signals if there are any signals. And the pain only occurs when the brain interprets those signals and the pain experience is created within the brain. So persistent pain is more to do with the pain system rather than the body tissues. Makes sense. And then once a patient understands that the brain is involved, then it can help us to talk about why certain things will influence the pain system, such as sleep and moods and things like that, because of their influence within the brain. And we can use examples if needed. And a lot of the time, I just like to use that pin example, stepping on a pin. And then we can say to patients that it's a simple example, but it's basically the same in all areas of the body. And it's the same for the vast majority of people with persistent pain. Over 90% of people with persistent pain will not have ongoing tissue damage. The problem is more about the pain system. Okay. So I'm going to pause very briefly to see whether, are there any questions before I go beyond that?
Not yet. I think we're just enjoying it. Still reminiscing about the apple, the red apple.
Okay, so what can we do in 10 to 15 minutes? Now, it's obviously a really challenging question and something I've thought about a lot. And I'm not going to give a sort of a list of things that we should do and things that we shouldn't do, because everyone are really experienced clinicians, and we don't need to kind of list things. So I wanted to sort of take it more from the consultation approach and the sort of themes that I see running through pain consultations when they go well. And at times I'm just going to consider a patient to give some structure to that. So we're going to just talk about Greg. We don't need to know very much about Greg really, just that he's a 60-year-old gentleman. He's got chronic or persistent low back pain for about 30 years. He's had 2 surgeries. He's had 10 injections. He's taking 6 medications. He's stressed, he's depressed, and he's struggling at work. So perspectives and objectives. This is really just to reiterate what I said at the start, that these are my own perspectives and reflections. They're informed by my own experiences and the experiences of others. I have no objective to tell others what to do. No objective to suggest I'm any good at any of this stuff. Really, it's just to promote a reflective thoughtfulness. And it's my belief really that when we really reflect on our pain consultations, it helps us to adapt them, to develop them, and ultimately to have consultations which are more rewarding for us and more effective and rewarding for our patients. Sorry, just bear with me. Okay, so thoughtful beginnings for me. So where did this all start for me? So I think my kind of fascination with chronic pain really started because of 2 reasons. And when I used to see chronic pain patients in general practice, there were 2 things that stood out to me. Number one was how often they just seem to be revolving around the system, between GP consultations, between pain management consultations, between consultations with other specialists. And they would just revolve and revolve without making any sort of meaningful progress. And the other thing I noticed was how often they would just say, thank you for listening. Thank you for listening to me. And I just found this really curious, because I just think, well, you know, you've had this pain for 30 years. You know, you've probably had more pain consultations than I've had birthdays. And for some reason, you just don't seem to feel heard. And that kind of feeling of, we must be able to do this differently, is kind of what drew me towards pain management. So this is a bit of a difficult slide, because it kind of considers a little bit what might not be working at times. And I have to be a bit careful there, because a lot of things are actually really, really good. But I do notice that we are gradually developing more and more sort of models of care. And we often approach consultations with a sort of menu of options. So, you know, we see Greg, who's 60 with chronic low back pain, and we might have a menu of options. We might have injections, medication, physiotherapy, psychology. We might have these things on our mind. It might be a slightly different menu, depending on whether you're working in primary care or in the pain clinic. But sometimes I do have a sense that we, maybe because the consultations are so complex and uncertain, that we will try to fit our patients to our model a little bit, to the options that we have to us, rather than necessarily really understanding what's going on for that patient. And the other thing that I've noticed is that quite often we tend to see pain as a single entity. So we do the biopsychosocial really well. We say, this is Greg, he's 60 years old with chronic low back pain. We do our biopsychosocial, he's stressed, he's depressed, he's struggling at work. But we don't necessarily always get into the actual pain and what is actually happening with it. So positive progressive pain management. So what I mean by this is just quite simply that whatever's happening for the patient, whatever we're doing for the patient, that they are in some way progressing in a positive way. They're not standing still, they're not going backwards, they're not revolving between services. They're just progressing in a positive way. And there's 3 elements that I have noted to run through patients who are progressing. And I'm going to just go into those in a minute. But one is a collaborative understanding that I will describe in a minute. One is that they've got the right support in place. And lastly, that there is some motivation, there is some hope, there is some motivation for what we are doing. And when I say that the support has to be right, I mean that really that it supports the pain management journey. So when we take Greg, who's stressed and depressed and struggling at work, we may hear his stress and we may select some CBT or some mindfulness-based stress reduction, referral to steps to change from our list of options. But if the story is actually that he's struggling at work because he wants to stay at work and he doesn't have anyone to advocate for him for the adaptations he needs, and that is driving his stress, then even though we might make a really good intervention for his stress, we may not see a positive progression in terms of his pain management. Just 1 second, my computer is telling me that it wants to restart, which it always does. It's going to give me 2 hours grace. Okay. So my reflection has been on how to do pain consultations that will as much as possible, get to that sort of positive, progressive place. And I've found sort of 5 ideas, 5 themes to be running through those consultations. And I'll list them and then go into them. So the first one is paying close attention to the story. The second one is narrative humility. The third is collaborative understanding. The fourth is nurture hope. And the fifth is mind the gap. Okay, so we're going to go into those one by one. So paying close attention to the story or to the narrative. So this really comes back to the fact that pain is a subjective human experience. Pain only has reality within a consultation because the patient tells their story and the clinician hears the story. So we can say that the story is about pain, but pain is the story. So everything that we need to know is in the story. And this brings us to this term of narrative humility. And this really means, in my mind, paying attention to the story without trying to write it yourself. And there's our friend Socrates there, who says that the only true wisdom is in knowing you know nothing. And we have to appreciate when we come to a pain story that we really don't know the story at all. And we certainly don't know what the next best step is for the patient. We might have some ideas about that, but we don't know. So when we listen to the story with this concept of narrative humility, rather than thinking about how we can fit it to one of our options, rather than trying to write that next chapter a little bit, even consciously or unconsciously, which I think, you know, we do a lot, then we bring ourselves back and we just pay close attention to the story, and we're more bothered about that than anything else. Okay. I can come back to these if I don't make sense. So collaborative understanding, then, brings us to that. So that means that by paying close attention to the pain story, the clinician develops their understanding of the patient's lived experience. And the collaborative bit that means that by telling their story, being allowed to tell their story, the patient develops understanding of their own story. And we are also able to add a little bit of scientific context, which can help to validate it. So an example would be that Greg tells us that he's on 6 medications and he's so frustrated because his pain is no better, and in fact, it's getting worse. And then we can say that, you know, he's not alone, Greg. It's a really common experience. And the reason for this is that many of these pain medications are not intended for long-term use, and they're known not to be effective over the long term. So we come to a collaborative understanding. So nurturing hope. I'm going to just take another drink before I talk about this picture. I'll just leave that for people to have a look at actually for 60 seconds while I drink. So this is a picture that I really love, and a painting, should I say, and it comes from something called Face to Face, which is a London-based project to describe facial pain through art. And this was actually done as a self-portrait for trigeminal neuralgia. But I just really like to, when I looked at this, I just saw so many patients' pain journeys and so many difficult life journeys. And you have the the valued, the positive parts of life, the right-hand side or the left-hand side, depending how you look at it here, in the bright colours, the lovely trees and the sky behind. And then the pain you see here is, of course, the black areas, and we can see how it's encroaching upon the good parts and around the good parts. In the sort of self-portrait, which I trigeminal neuralgia, it sort of represents the two sides of the face. And this is this kind of claw-like structure, which represents a flare of pain or a flare of trigeminal neuralgia, and how those things just come out of nowhere and hang over people. So I see quite a few arguments around about whether we should nurture hope. And I just want to say definitely yes. You know, I see a lot of things written on that we should be careful not to promote false hope or false expectations. So for me, the hope is the bit of light that you can still see on this picture at the end of the path. And without this hope, it's very difficult for patients to have motivation. This does not mean giving people false expectations. It doesn't mean telling people that their pain's going to definitely go away, that we're going to refer to the pain clinic and they'll have a magic cure. It doesn't mean any of that. It just simply means, I think, that through listening to that pain story and through that patient feeling heard and validated, that they will have hope. And also knowing that there's some sort of follow-up to come. Let's have a go at this. Let's refer you to the pain clinic, or I'll see you again in a few weeks or a month or something like that. Those sort of things nurture hope. And without hope, it's very difficult to have motivation. And without motivation, it's very difficult for people to make positive progression. Okay. So mind the gap. This was my own sort of little reflection, little concept that I came up with primarily through just observing discussions in MDTs, where because we don't have the patient in front of us, you know, to some extent, we're not very good at narrative humility, and we do tend to sort of fill gaps in a little bit. But often these patients have such complexity, and, you know, they're under this specialty and that specialty, this treatment and that treatment, but they're not progressing. So mind the gap is really just about asking why. What is the gap in this person's care? Not to just pick the next thing off the list that we know can help pain patients, but to really, through listening to the story, look for the gap. Pain is not a certain approach. It's not a model, a service, it's a person's story. And when we pay close attention to the story, we pay close attention to the pain. And when we do this without agenda or preconceptions, the gaps will appear. So in the case of Greg, he's 60 years old. He's got chronic low back pain for 30 years. He's had 2 surgeries, 10 injections. He's on 6 medications. He's stressed, he's depressed, and he's struggling at work. When you say to him, so when do you actually have pain? Is it all the time, or is it certain times? No, I really just have pain when I move and when I try to do things. Okay, so when you rest, when you get yourself comfortable, is it okay? Yeah, it's okay then. Okay, so how long have you been moving when you actually have pain? About 20 minutes. And what do you do then? Well, I keep going until I basically collapse. Okay, so in 30 years of having 2 surgeries, 10 injections, has anyone ever talked to you about the really difficult relationship between pain and movement, and how that can be modified and adapted and worked on, and given you any support with that? No, never heard of that. So that is just probably the most common example I come across of mind the gap. What is the actual pain story here? What is the gap? So once people are kind of looking for that, then we do kind of have to know a little bit about, we want to gain some confidence in trying to help our patients with those things. So I've just put, I'm not going to go through them, but I've put a list up there of just a few elements of pain which might be a gap. And it is beyond this talk to sort of go into all of those, but there are ways and means that we can start to develop our confidence with looking at those things. So put a few things up there. So we have the 10 footsteps approach, which is developed by Live Well with Pain. So this is basically 10 areas to work on, and 10 gaps, if you like, which can form a positive progressive journey for the patient. It's really common, you might have seen it. It's Red Whale use 10 footsteps. So you might have come across it like that. And you can go to the Live Well with Pain website and you can look at those, and there's lots of resources on there. Live Well with Pain also have this thing called Footsteps Festival, which is basically a sort of interactive festival looking at various elements of chronic pain and how we can support patients. There's all sorts of resources on there, everything from movement to moods to cooking. And Flipping Pain is a national public health campaign, which is closely affiliated with Lincolnshire Pain Team as well. And they've got huge amounts of professional and patient resources as well. We hope during 2023 that we're going to start to develop training around the 10 footsteps that GPs across Lincolnshire will be able to tap into. That's in progress. So my key ideas from all of that, and I appreciate it's quite philosophical, I suppose, but I guess the key ideas are be patient. We all know really that we don't, have significant impacts on chronic pain in just one consultation. This is about a therapeutic journey. Pay attention to the pain. Add some education if possible and carefully nurture hope. Mind the gap. What is the real gap here? Support the patient to develop their own story and risk the temptation to write it. If some of these kind of concepts have resonated a little bit or you found them useful, just try it out and see how it goes. And develop your holistic approach through using resources like 10 Footsteps, Red Whale, and Flipping Pain. And if it's really complicated and it's clearly going to take a lot of time, then just consider the pain service. It's really, really good to be able to just hear the pain story, validate the patient, see where the gaps may be, and let the patient know that there is support out there, and that when you refer to the chronic pain team, that they'll be able to support you with some of these gaps.
Before we go on, sorry, just jumping in. There was a question that I think kind of answers itself on the chat box for you there, Graham. And I think it kind of covers what you've said, which when you were talking to us about the red apple. The question for the colleague says, when you nurture hope from a patient perspective, are you giving them a subjective expectation with their pain? I think it sort of somewhat answers itself in the sense of what hope means in itself. It's a subjective thing. It's a feeling of expectation and a desire, for good outcomes. But I bet you will have your philosophical spin on that. Please go ahead.
Yeah, so I suppose that's a really good question. I suppose probably to some extent don't pull the hope and the pain together that closely. Clearly they're related, but for me, nurturing hope is more about, it just comes back to that people feeling that there is someone here who is listening, someone here that is ready to support, and that there are services that can be provided, and that we can help you. And I think it's paying attention to the language that we use as well. There's lots of bad language out there. We talk about degenerative spines, we talk about tears, we talk about crumbling spines. People say that your back's knackered. Somebody told me today that the surgeon had told them that in a few years his rib cage would be on his pelvis. So these sort of things do not nurture hope. So I think it's paying attention to our language and just being open to the story, hearing the story, validating the story.
Excellent, excellent. Thank you. Before you go on to the NICE guidelines, I just want to say thank you. That has been, you've given us the holistic, philosophical, human experience away from the medication. I noticed you didn't talk about medication there, and I know a lot of my colleagues want to ask you questions on medication, and I hope it's okay if we potentially, or maybe not potentially, I'll be directly ask you these questions, and that's okay, because I know it's a daily experience for us. And as you know, rightfully as a GP yourself, medication are some of the best tools we have, apart from obviously the time to converse with these individuals, which is becoming rarer every day, and then more valuable every day. One of the things you said back in the beginning of your slide that I wanted to just touch on, if it's okay, is you were talking about chronic pain and obviously nociception, and the fact that tissues heal in less than 3 months, and if it's longer than 3 months, we should be thinking there is no tissue related pain signal. It's more of just the body telling you there's some sort of concern there. When we have patients who have known back problems, and by back problems I mean spine problems, and more specifically things like tears, like you were speaking about, or prolapses, and if for whatever reason, based on their background history, they can't undergo surgery, or they're on a long waiting list for surgery, how do we address those concerns? Because obviously there is a physical concern. There is that concern whereby there are pressure symptoms affecting them at that point in time. There is that tissue that from time to time is causing physical strain. And we do know we want to manage their pain until they get surgical intervention if it's will be useful for them. So in those situations, there is still chronic pain. There might still be a tissue element of the chronic pain, and we need to still manage that. We tend to see a lot of those these days because of the COVID pandemic, the long waiting lists, and they keep coming back to us. We'd love to know how to manage those patients' pain, because we can be holistic with them about all the other physical things, but there are also long physiotherapy waiting lists and all of that as well. So we need to manage them as best as we can, and we're the easiest people for them to reach. So I wonder, how can we use medication safely, obviously without necessarily using opioids, because I know there's no particular evidence behind that for chronic pain. What are the other tools you would say would be useful to have in our arsenals that we should be using more of, that is safer for patients? Medication, right? Thank you.
Thank you. Yeah, it's an excellent question that I need to just split down slightly. So just going to try and pick up on a few of those points. So with respect to medication, in a minute, we'll do our little whistle stop thing about that, I think, Ali, and then I'm hoping we'll have at least kind of 20 minutes, but we know we've got no time pressure for people to ask questions if they want to. Pain medication are not your best tools. They are, perhaps you feel like, your only tools at times, but they are definitely not good tools a lot of the time. The vast majority of people with chronic low back pain, persistent low back pain, okay? So chronic low back pain is the main persistent pain problem. It accounts for something like 85% referrals to the pain service. The vast majority of people with chronic low back pain, over 90%, do not have tissue damage. When you see MRI scans that talk about degeneration, talk about tears and all that kind of stuff, you can lump all of that under normal age-related change. Over 90% of people in their 60s have those changes, but most of those people do not have pain. People develop persistent pain and then have an MRI scan done, which shows some normal changes about their structure, and people put that together with their pain. So if the spinal surgeon sees something specific, such as a disc sitting on a nerve, which directly correlates to their radicular pain, then that is a surgical target. Clearly, there are things around cauda equina syndrome and malignancy and stuff like that as well. But over 90% of patients have persistent back pain because they have persistent pain, which means that the brain perceives that that area requires ongoing protection, but there is no ongoing relevant tissue damage. It is just normal age-related change. So we should be managing as chronic pain, and hopefully from the sort of philosophical perspectives that I've suggested. Does that sort of answer it, Leggy?
Yes, for those obvious age-related changes, I appreciate that we shouldn't medicate and medicalize them. I appreciate that very much. I was trying to cover the patients who we know are either waiting for surgery because there is a target to surgically treat, or the surgeon has decided that, unfortunately, due to your other comorbidities, even though you need surgery, I can't do surgery on you because I'll have a poorer outcome. How can we manage those with medication? Because obviously, holistically may not be sufficient. And by holistically, I mean non-medication methods may not be sufficient for them.
Yes, I understand, yes. So two slightly different issues. If the patient is awaiting surgery, then you should still really manage in line with NICE guidance. There is, there would be a query in your mind whether you would consider opioid medication if you think that you're doing that for a short period of time. So say the patient's going to have surgery in 6 months. The potential downside to that is that opioid medication has also been linked to poorer outcomes post-surgery. And pain post-surgery, and many people who have back surgery will continue to experience pain post-surgery. So my answer would be really that if these patients are tricky and they're complex, and these are good patients to refer to the pain service, and the patients who are awaiting surgery would be accepted under the waiting well scheme. And they would be able to have pain education, holistic support, explanation on all these things via the pain team.
Excellent, thank you. The waiting well scheme, can you please just very briefly tell us what that is? What is that?
So waiting well is primarily for people who are on long surgical wait lists. And it's just to try and help them wait well, basically. And the pain service is signed up to the sort of pain element of that. So if you have a patient who's waiting for surgery and they're on a long wait, you can refer them to the pain service for a one-off waiting well appointment.
Oh, fantastic. Never heard of this. Thank you for sharing that with us. I'll definitely share that in the future. Thank you. There is another question here very quickly from another colleague. She's asking that, could you explain what bone-on-bone pain means? Obviously, patients are being told about this based on X-ray findings, I suppose. What's your take on that terminology? And what can be done pain relief-wise, in your opinion?
Yeah, so I mean, bone-on-bone is probably nonsense most of the time, but generally speaking, people are referring to that kind of severe end-stage osteoarthritic joint, where radiologically it appears to be bone on bone, but you still manage osteoarthritis in the same way. It doesn't change management. The only progressive thing from an osteoarthritis perspective is movement until the point where that patient has their joint replaced. The only thing that really makes a difference in research is movement exercise, essentially. Yeah, so we should still just manage osteoarthritis in the same way that we would normally manage osteoarthritis. Presumably, if they're saying it's bone on bone, most of the time, they might be considering surgery. But I suppose if you're in that place where the BMI or something like that is preventing surgery, then yeah, absolutely manage in the same way, and painting can support with that.
Excellent, thank you.
That's okay. So as I promised, timings are going a little bit awry. Ali, do you want to just highlight, like you're going to do, the sort of 4 nice guidelines here that we're kind of used?
Yeah, sure. So this, I guess, is our interpretation of the guidelines as a pain service, and how we approach the guidelines and integrate them, acknowledging that at first look some of the guidelines seem to contradict each other a little bit. So the 4 guidelines that we look to predominantly are the chronic pain guidelines, so NG 193, neuropathic pain guidelines, the new OA guidelines, which have just recently been published now and updated, and the low back pain and sciatica guidelines. So I'm just gonna take control again so I can change the slide. So really, I won't go through these slides in detail just because of time, and I was really conscious tonight that I didn't want to just start reading guidelines back to a room full of GPs that probably know these guidelines much better than I do. So I've done a little summary for each guideline. Sarah, if you want to.
Sorry, can you go slowly through the slides if that's okay, just so we can have a quick glance at them? If you go back to the.
Yeah, sure.
Yeah, thank you.
So chronic pain guidelines are essentially just saying only antidepressants are recommended in primary persistent pain, and that should be irrespective of mood. We've got neuropathic pain guidelines that recommend the 4 neuropathic pain meds, so amitriptyline, duloxetine, and then both gabapentinoids, and that it's reasonable to cycle through if one's not effective or tolerated. I kind of put a question there as something to question and discuss, that there isn't really any good evidence that if one gabapentinoid doesn't work, that another will work. So it's something to consider, opposed to just cycling through. And tramadol's the opioid recommended by neuropathic pain guidelines, but only as a rescue medication. So lowest possible dose, shortest possible time, which minimizes the risk of building tolerance. And capsaicin, if all else fails. So certainly in my personal experience, I don't think I've ever encountered a patient with nerve pain that capsaicin has been particularly useful where all else has failed, but that it's something we can consider. And for the exceptional cases, PACEF allows the pain service to consider lidocaine plasters through our MDT process. And then NG59, which essentially now anti-inflammatories, lowest possible dose, shortest possible time, and only weak opioids for acute low back pain, and not routinely even then. So quite limited in terms of chronic pain recommendations in NG59. And the new OA guidelines have gone in a similar direction. So again, anti-inflammatories, lowest possible dose, shortest possible time. And weak opioids, again, for infrequent short-term use, breakthrough pain. And then the questions I was just going to pose before the before the comfort break, really, just to stimulate some questions, perhaps, is the question on gabapentoids for radicular pain. Obviously, NG59 says that we shouldn't consider it, but then neuropathic pain guidelines suggest it as an option. Amitriptyline, duloxetine for radicular pain, an antidepressant for low back pain. So that's just where there's a little bit of conflict between guidelines. So just thought they'd be good queries to raise to stimulate some questions after the comfort break, perhaps.
I'd perhaps suggest that, given that we're obviously taking our time tonight, that if people want to, I've got a few slides which we might do for 5 minutes at the end if necessary, just really about how we talk about pain medication when we can't prescribe it. But maybe at this stage, does anyone have any specific medication questions around the guidelines, applying the guidelines that we can answer? Or if not, I'll do those slides while people think about it.
Very quick question, and this is with regards muscle relaxants, and what your take is on that, because I do see that obviously in the short term, acute pain, there was a role for antispasmodics in certain cases, but then we do hear of patients who get flares, obviously, which we expect those are acute on chronic concerns. What have you found or to be most effective in that situation from a muscle relaxant standpoint? Is there a place for it? Because we know that there are some people use diazepam, and for some more complex cases, some people use methylcarbamol, and then some other people use even more fancy stuff there. But I just want to know where your thoughts are on the muscle relaxant medication, and where's the place for them?
Yeah, absolutely. So NICE, in terms of NICE guidelines that we apply to chronic pain, NICE do not consider there to be a place for muscle relaxants. So we generally do not prescribe them out of the pain team because we're primarily concerned with long-term regular treatments. Obviously, things are slightly different in general practice, and if muscle relaxants such as buscopan and things are methylcarbamol are helpful for patients, particularly in short-term use, then I'd see no obvious reason not to use them as an independent prescriber short-term, but they're not included in NICE guidelines for chronic pain. With respect to diazepam, again, sort of 3 to 5 days for rescue therapy is obviously a common treatment, and if it works, then fine. The time we need to be really careful with benzodiazepines is when patients are also on particularly strong opioids, gabapentinoids, because the combination of those treatments increases the risk of nocturnal hypoventilation. And there is an MHRA alert about that. Excellent.
I saw that going around the other day or a few months ago. Thank you for that. There's a question. You did mention earlier on about group therapy sessions and how there was good feedback from patients there, Alistair. One of my colleagues here is asking, is there any evidence that shows that they do work? I mean, apart from the anecdotal evidence from your patient's experience, are there actual written evidence about this? That's the first question to you. And then the other question, I believe, is to Graham.
I think that's always a tricky question, and it comes down to what do you mean by improved chronic pain? Because we know that despite best care, whether that's medication or active-informed pain rehabilitation, most patients' pain intensity or pain frequency won't change. And if it does change, it will be by a small amount. So there is no good evidence to suggest that group-based therapy is able to resolve people's chronic pain. Although we've seen certainly cases anecdotally where people have reported significant shifts in pain, whether that's maintained at a year or 5 years or 10 years, that's to be seen. But what there is good evidence for is that quality of life can improve with these programs, and we do see people shifting towards value-based goals, and there is that objective data in terms of things like PSEC that measures this, not arguably in the best way, but it's a reasonable measure of self-efficacy and quality of life. And you know, when you compare the shift in those sort of things between group-based therapy or one-to-one based therapy and medication by itself, there's, you know, definitely a difference there.
Excellent. Thank you so much for that. The other question, which I think will be to Graham here, is what are your thoughts around restless legs and pain management, or restless legs causing pain specifically? Is that a thing? Do you manage it as restless legs on its own, or is there a pain to manage as well? Obviously, we know restless legs management according to the NICE guidelines and the ropinerol, etc. But I suppose that my colleague here is talking about pain related to restless legs.
Yeah, absolutely. It's a really good question, and one of those kind of grey areas, I suppose. So yeah, absolutely, restless legs is associated with unpleasant sensory sensations, and for a proportion of patients that is described as pain, and restless legs often coexists with chronic pain. So the interesting thing is, of course, that gabapentinoids are one of the first line treatments for restless leg syndrome, and there are going to be times when you don't want to use drugs like ropinerol, and you might be going for gabapentinoids. So this may create a scenario, for example, with a patient, let's say we have a patient who's got fibromyalgia and restless leg syndrome. From the new NICE guidelines, NG 193, we're now advised not to use gabapentinoids and to just prescribe an antidepressant. But if someone has coexistent restless legs, then that might be a scenario where you may consider a gabapentinoid first. It's worth remembering that you become tolerant to gabapentinoids. They are dependence-forming drugs, and tolerance occurs in pain, and tolerance also occurs in restless legs.
Excellent. Thank you very much for that. We'll let you carry on with the rest of your slides.
Okay, so I'll just go very quickly on these. So obviously these days, a lot of the time we're having to have consultations because consultations where we're not going to prescribe medication. And that is often because, as one of the questions said, the patient is already prescribed lots of medications, or there is just nothing appropriate or as per NICE guidelines left to prescribe. And, you know, I think there is a tendency to just want to do something. We're all like that, and we want to help our patients, but we have to remember that we are, you know, the sort of Hippocrates do no harm. And Kathy Stannard, who is a leading pain clinician and was involved in the NG193 team, I think she led the NG193 team. This was her quote: "A prescription for medicine that doesn't work is a prescription for harm, and no one wants that." And I think there's a bit of mindset change to happen here. You know, we certainly would not, if we wanted to treat a child with a strep throat or something, we would expect to be pulled up on it if we handed out some metronidazole. And we have to remember that just because it says that it's a painkiller on the box, it doesn't mean that it's for all types of pain. So do I have control? I need to take control. Okay, so the sort of things I like to say, the role of medication in chronic pain is limited, and that is because, number one, it's just less effective in chronic pain. Number two, many patients will experience adverse effects, if not in the short term, over the long term. So, for example, we talked about gabapentinoids. People will have weight gain, fluid retention. People have cognitive effects, which reduce their ability to cope. And ultimately, those things can mean that their pain experience is worse than when they started. And with all opioids and gabapentinoids, people develop tolerance to those medications. Pain medication is very much part of a pain management jigsaw. That is something that's developed by NHS 5. And I find that quite a useful way to explain to people. It's not the whole picture. And sometimes we just have to say to people that if you've really exhausted that piece of the jigsaw, and in fact, your pain is getting worse despite that pain medication, then it's not always going to be about just trying another one. Sometimes we need to try some of the other pieces of the jigsaw. And obviously the pain service are there to provide those services if you need to access them. Difficult conversations, you explain all this and the patient says, well, yeah, but my pain is real, my pain is not like that. All pain is real. All pain is an experience in the brain, whether you've had your leg blown off or whether you've had 20 years of back pain. All pain is an experience created within the brain. There must be something you can prescribe me. Well, sometimes, of course, there just isn't, and it's about going back to that pain management jigsaw. Pain medication is part of a management jigsaw. So what are you going to do then? Well, for me, that you get the answer to that question by listening to the story and minding the gap, which is why I wanted to go into those philosophies. This is inhumane. I have on occasions been told this kind of thing, and you get blamed personally for the fact that pain research has not found the answer yet and this kind of stuff. And sometimes that's just about distancing yourself, I find, from that. It's not a personal thing. And you can remind patients that, we are expected to practice within certain guidelines. And I think most patients are accepting of that. Before I go on to that very last one, these are the difficult ones, but what I would say is my overriding experience that when you just listen to the story, is that the vast majority of patients are absolutely fine about these difficult conversations. So I may as well give up. And I just put this in very briefly because occasionally these sort of consultations lead on to the expression of suicidal ideation. And people living with chronic pain are more likely to develop mental illness, and suicidal thinking and completed suicide are more common in chronic pain as well. These things tend to be linked to low self-worth and hopelessness. And sometimes, if you have no self-worth and you're hopeless about the future, then the natural kind of extension of that is, I might as well not be here. And we just go back to the same things, really. Explore the story. When we are used to doing depression consultations and speaking about suicidal ideation, and we just have to accept that will happen sometimes in pain consultations as well. And when we explore it, if there is suicidal intent, which, to be honest, I find is pretty rare, but if that does happen, then of course we involve others at that stage. And this is an element of pain then that we just need to, this is part of the pain story, and we just need to follow it. And thank you for listening. Sorry, it was a bit long. We've got a few minutes left for a few more questions.
Excellent. Thank you both very much. Very, very useful tandem presentation. We really enjoyed it. Thank you very much. Very quick question from my colleague there. She's asking about phantom limb pain. And what are your thoughts on this? How long do these experiences last, in your opinion? If this is something you've experienced or you regularly experience. And I think the follow-up question to that would be, do you use any specific motivational consultation techniques regarding pain management cases?
Okay, shall I take the first one then, Ali? So phantom limb pain. So people obviously there's phantom limb pain, and then there's sort of pain in the actual sort of stump itself. So really just manage that in line. You know, you just explore the pain, and a lot of the time that's about, from a medication perspective, that will be about managing in line with CG173, you know, nice neuropathic pain guidelines. My experience, how long does it go on? To be honest, the people who end up in the pain clinic with phantom limb pain, my experience is they're pretty stuck with it. Yeah, difficult thing to manage. Do I use any specific motivational consultation techniques? I'll ask you that in a minute, Ali. I don't personally. I know people do use things like frames. My just personal belief is that for me, I find that when you I just keep going back to that, when you really listen for the pain itself, when you really explore that story and the patient, you develop that collaborative understanding. So you're not just saying, well, this is what you need to do, and then needing to motivate the patient. Because the patient comes to understand why there's certain things that may be suggested, then the motivation lies in there. You know, if you feel that you understand why something is being suggested and you have some hope around it that it might do something, and you feel supported to have a go, then I find that that will naturally motivate the patient to have a go in most cases, in most scenarios. Ali?
Yeah, I agree. So maybe not specific techniques. I guess more kind of overarching philosophy would be a better term. I agree that patients tend to be really motivated most of the time anyway. You know, a lot of these patients have been seeking various opinions for several decades, going from GP to physio to consultant to pain service to GP, and you've got to be fairly motivated, I think, to attend all those appointments and seek those referrals. I don't think motivation's often lacking in patients. I find the creative hopelessness piece can be really useful. So, you know, helping patients to reassess their goals and how their current goals have perhaps been a barrier to engaging with life in the way that they want to. So, you know, really assessing if that diagnosis seeking, resolution of pain seeking is having an impact on living life the way they want to live it. And if you can nudge and shift patients to set values-based goals and to focus more on the overall impact that not only pain but mood and the whole picture is having on their life, then often that leads to motivation to engage with some of the things that we think are more helpful. You know, that can cause a shift from the pain control interventions like injections and medication to it makes more sense to patients to engage with changes in behavior and lifestyle if the goal is quality of life improvement and not finding an answer or a resolution. If that makes sense. I'm not sure I articulated that particularly well.
I think summarizing what you've said there, which I think you did articulate it quite well, is that what's the patient's goal? And is that goal relevant now compared to what it may have been prior? So re-establish what that goal is, help the patient understand if it makes sense, and maybe they might need to create new goals with your support or with our holistic support. So I think you articulated that very well. Thank you. One of the other questions here by another colleague, which I think I will answer if it's okay. This is from colleague from Lucy, who we know quite well. Lucy's asking basically if there's any need for a referral or just asking a question, what's the best way to get in touch with yourselves if we don't know. The answer from what we've understood so far is there's an A&G, so there's an advice and guardian, similar to the way we have in other specialties, Lucy. So you can just simply send it off by your secretary and they will answer usually within a couple of days. So that was news to me as well. I've never used it, so I'm going to be using it. So thank you for reminding us. And for the other individuals who are curious about patients, because the waiting lists are very long, there is a waiting well service, which again, is news to me and I'm loving this, which also equally works, and that's for patients who are waiting for surgery, who expecting surgery. There is a service commission via the pain team to support them. There's another question here. First of all, a lot of thanks to saying that it is a great talk, both of you. Thank you so much. And it's a lot to unpack and reflect. And thank you for reminding us about the importance of listening. I know we do listen, but again, it's important to be reminded to even listen more. And with this age of techniques and interventions, thank you for the wonderful updates. And I hope you're all doing well. That's from Sanja Moretic. Lucy's thanking you all as well, and Rubina is thanking you all, as well as Hanatu. So thank you for your time today. Really appreciate this. It's nice to be reminded about the philosophy behind pain and the subjective experience of pain, and the fact that it is real for the patient, for the person, and for us when we interact with them. So thank you so much for the reminders. I know we've taken a lot out of this, and I know more questions will come later on. Is it okay if I can pass those questions on to you both in the future by email?
Yeah, sure. Absolutely. Yeah, absolutely. And thank you very much for having us. And yeah, any questions are welcome. And also, if anyone's interested in pain and wants to do, occasionally people come and sort of do a session in the pain clinic, shadow a session in the pain clinic, then anybody is welcome.
Oh, that is excellent. I might actually take you up on that. I know quite a few people here have shown interest, so we would love to do that. I see someone already is putting up their arm there, their hand. Rubina Mogal is asking already. She's very keen. So would it be okay if I compile a list, possibly, or tell them to email you directly? Do you have a preference, Graham?
Yeah, just send them to me on you've got my email letter.
NHS, lovely. I'll forward that on. Not a problem at all. Thank you again. Thank you, Alistair. Really appreciate your time today as well. And we'll be in touch. All right.
Thank you.
Thank you. I'll share the details with you all. I can see you're all interested. Actually, you know what? If you all stay on, the ones who are interested, stay on the talk. I'll copy out Graham's email to you here, because in case I don't see you on the WhatsApp group, because I see some names I don't recognize from our group. All right. Thank you, Graham, and thank you, Alistair. We'll let you leave, and I'll sort the rest of the team. All right. Have a good one.
Thank you.
Bye-bye.
Thanks. Bye.
Bye. So I'm just going to stop recording there.